glenohumeral joint. Gleno pertains to the scapula, the concave surface of the scapula, the socket for the shoulder. And then you have the ball, which is the head of the humerus, right? So you have the glenohumeral joint, and then you have different joints of the manus, the carpal metacarpal joint, metacarpal phalangeal joint, and then you have the PIP and DIP, the two interphalangeal joints. Then we got into the neurological complex. So the brachial plexus, we talked about dermatomes and myotomes. Blood supply. So we branching off of the aorta is the subclavian, which is deep to the clavicle, the axillary, axillary, which is the name for another name for the armpit, the brachial, and then radial and ulnar, and then palmar arches. And now we're getting into some actual pathology. So again, like I said, I went through this a couple times, but the recording didn't work, so we'll see if it works this time. So here's the humerus right there. That's a pretty bad fracture of the humerus. So we're going to go through these. We're going to talk about MOIs. We're going to talk about treatments and signs and symptoms, and go from there. So first thing we're going to talk about are clavicle fractures. So with the clavicle fracture, it is the most common fracture. Can't even see that, can you? Is the most common fracture of the upper extremity, the UE there, the upper extremity. Now don't get that confused with the scaphoid, right? So the scaphoid is the most common fractured carpal bone, but in your entire upper extremity, your clavicle is fractured the most. The MOI, mechanism of injury, is the, nope, that's not it. It's the fouche. So fouche, if you remember, is fallen on outstretched hand. So if you could picture it, let's say you're skiing, you fall going forward and you put your arm out to break your fall. If you keep your arm straight and locked, right, that energy is going to transfer up your arm to the weakest spot, which is the mid third of the clavicle, where there is the middle third of your clavicle where there's a curve. So just to show you, so there's the clavicle there, and then so you could see on the middle third, so it's going nice and straight, and then all of a sudden there's this curve, and about right there. So if we were to break that up into thirds, I know it's not even, but we'll call it even. This one right here is where the fracture happens. So when that happens, it doesn't necessarily require surgery. It just, I guess I'm jumping ahead. So 6 to 8 weeks it takes for a bone to heal conservatively, right, without any surgery. But if you have surgery, it'd be a little faster than that. But you always, if you could avoid surgery, you want to avoid surgery, right? Having surgery is just like adding collateral damage to the body, right? It's an operation. Things can go wrong in that. So, signs and symptoms for a clavicle fracture, there's definitely going to be some edema, right? Some swelling, some ecchymosis. There's going to be a deformity, and notice that when you check bilaterally. Decreased range of motion for sure, especially when you get to like 40 degrees of, so the check marks flexion, extension, and then abduction. Whenever you start to move your arm, if you were to put your one hand on one shoulder and then move that arm, you would then start to feel when your clavicle actually moves, and that's when it would start to hurt. So for treatment, you want to immobilize, you want to get them to the ER, and then something that they'll probably do is get them in a figure 8 brace, which tries to help immobilize the clavicle, because a lot of times there's delayed healing with the clavicle because you move it so much, right? Everything you do to put your shirt on, to brush your teeth, to eat food, right? You move your arm, and that could disrupt the healing process. Here's a video that I'll show to you now, and it's of like a person that has fractured their clavicle. Maybe. Obviously, it's probably a little graphic, so watch out.
This video will illustrate how a broken collarbone or fractured clavicle is repaired. in this case, a professional motorcyclist who had fractured his right collarbone 1 year prior, also while racing. He continued to compete only 1 month after the fracture healed, and now presents 1 year later with a similar fracture in the left collarbone. All of this is 1 year after he broke his right wrist, which was also repaired. As you can see, incision is made here in the area of the bruised skin. Dissection is carried down till we identify the fracture fragments, which are clearly seen. These smaller fragments are called butterfly fragments, and they need to be placed together and stabilized for what we call provisional reduction. You can see one small gold screw was placed to hold the butterfly fragment, and now a plate will be applied which will allow for much stronger fixation and allow this competitive athlete to get back on the bike much sooner. This was a similar technique as used for Lance Armstrong. The fluoroscopy or live x-ray demonstrates the excellent reduction, good position of the plate, despite the fact there are still some small fragments that are mildly displaced. The subcutaneous closure is done prior to what we call a subcuticular or a cosmetic skin closure, which is done since this is a very visible area on the body. This was done in an outpatient setting, and the patient was able to return to his bike and continue winning in his sport.
There we go. So there's a nice little video, a little extra information for you there. Now moving on to scapular fractures. I guess I haven't erased these notes, but let me go ahead and erase these notes. All right, so scapular fractures. Okay, so your scapula is actually fairly uncommon, right? It's kind of, so here's the body of your scapula, right? Let's get back to this guy. I don't know if you think about it, if you've ever like talked to somebody that's fractured their scapula, right? So there's your scapula, right? It's an irregular bone in shape and kind of its location. It's not your typical kind of bone. So it's fairly uncommon to fracture. We're going to talk about two spots that it fractures. Oh my goodness. Sorry, I'm still getting, used to everything. I'm going to talk about body fractures, where you fracture the body of it. And we're going to talk about avulsion fractures, so this part right here, right, that's called your coracoid process. And we're going to talk about fractures of that. All right. So let's get back into this. We'll talk about these scapular fractures. That's going to be a pain if I have to do that every time. All right, so scapular fractures. So uncommon, right? Definitely to the body, right? So uncommon fractures to body. But not really commonly, but more often than not, you're going to have an avulsion fracture, which is more common. And that happens at that bony landmark right there, which is called your coracoid process. So those avulsion fractures are more common than the body fractures. If it's, so MOI for the body would be direct blow. That's like a backwards arrow. An MOI for avulsion is just like forced movement. So let me show you what I mean. Let me show you. So an avulsion fracture, I wonder if there's there's a video that talks about avulsion fractures. So avulsion fractures, so muscles attached to bone via tendons, right? An avulsion fracture is where the tendon pulls off a piece of bone. So let me show you. So if we look here, so we've got to remove a couple things. So your pectoralis minor attaches to the coracoid process. Your biceps brachii attaches there, but the one that tears it off is the coracobrachialis. So if you could just picture there, right? So if you could just imagine, so this right here would be forced off and a piece of bone would come with it, right? So that'd be an avulsion fracture. And I don't know if you could kind of see, but it's fairly common. It's common there anyways. Let's get back to this page. And I don't know if you guys have ever palpated somebody's coracoid process, but it's super tender to the touch. I don't know, try that out on your sibling or something. Like just put your thumb right there on somebody's coracoid process, and it's fairly tender. All right, so scapular fracture. So signs and symptoms, deformity, maybe, just depending on where. It is super painful though. Definitely tender to the touch. We're gonna do plus sign for positive. Decreased range of motion, kind of similar to clavicle fracture. Okay, so treatment, we're gonna immobilize. We're gonna send them to the ER. They're gonna get an X-ray, all that sort of stuff. Now there's two very important treatments. Okay, so body fracture, FXX fracture, important treatments. Okay, so here's number one, here's number two. Okay, soft tissue work and scapulothoracic motions. Okay, so let's talk about, so let's say someone do number one over here. Okay, so soft tissue. So your scapula sits right up against your ribs. Okay, so you can see and in between that space, see that gap there? There's muscle there, okay? So let's say you fracture the body of your scapula. Your body heals itself by laying down like, I'm gonna do it like this. So your body heals itself by laying down all this like collagen tissue, so your body just lays it down. And it does some other stuff for bone healing, but all this stuff just to like heal it, okay? What that causes is, it helps it heal, but now you have this big adhesion right between the scapula and the ribs. So then you go to move and your shoulder doesn't move right, which is problematic, especially if you're playing a sport that you need proper shoulder movement. If your scapula doesn't move right, then your shoulder doesn't move right, and then you cause issues. Okay, so soft tissue work will help break up adhesions, increase range of motion. Okay, let me do this. That ain't gonna work still. Okay, we'll make it work. All right, so number two, scapulothoracic motions. So those are motions that happen in the scapulothoracic region, right? So we're talking like retraction, protraction, upward rotation, downward rotation, depression, elevation, and elevation. Sorry if you can't read that. But so these are very important when it comes to body fractures, because, and obviously not a way like further down the line in the healing process. But if you don't do these, it's not going to heal properly. And if it doesn't heal properly, you're just going to have shoulder problems the rest of your life, which a lot of people probably don't want to have. Maybe that's better. Okay, so those are scapular fractures. Let's talk about humeral fractures. Most commonly, for sure, like I have it underlined already, for humeral fractures, a direct blow. Most commonly at the surgical neck is the most common location. And a lot of people, this is where my body, my choice comes into play, all right? Okay, so a lot of times it gets confused with the dislocation. All right, so let's just say we're somewhere, somebody fractures their humerus, and some parent like, oh, or some coach like, oh, it's dislocated. I know how to fix that. And they grab this kid's arm and start like yanking on it, but actually it's fractured, right? So I know I talked to you guys before about how I tell my boys, you know, your body, your choice. Don't let some random person just come and start yanking on your arm, right? Because it could be fractured, right? That'd be bad news. Okay, so treatment. So there would definitely be a deformity. You'd have some edema. You'd have some ecchymosis. Definitely decreased range of motion, very much. Very. So splint, refer, and you might have to treat for shock just depending on how bad they're feeling. All right. Now let's get into shoulder sprains. So you have a couple different joints that we're going to talk about. We're going to talk about the AC joint. We're going to talk about the glenohumeral joint. Okay. And I should probably move this like there. Okay. All right, AC joint, acromioclavicular joint. So this is where you sprain. You could sprain the AC joint, and some people call it shoulder separation. Okay. MOI for this, for sure, is a direct blow on the lateral aspect of your shoulder. This happens a lot in hockey where people get checked into the boards. This happens a lot in football where people get tackled. Like super common injury for like a quarterback. So they're like running with the ball and they get sacked. And when they get tackled, they get their shoulder pushed completely into the ground. And that pressure causes your clavicle to move upwards and then separate that joint right there. So it's kind of crazy. This has 6 different types, grades or types. And now let's go through this. So type 1, so we're going to go through like signs and symptoms. So type 1, mild edema, not bad. Pain with 90 degrees of abduction, so not bad. No deformity. And really, so type 1, you could probably play with it, right? It's not too bad, but you always, so type 1 can turn to a type 2 to type 3, and so on. Type 3, so grade 3 sprain of a ligament, moderate edema, definitely got more pain with abduction and flexion. Check bilaterally because that swelling, right, you're going to be able to see that. Now grade 3, type 3 is where it gets a little bit more serious, okay? Conservative treatment, really? Even for a grade 2, conservative treatment, some docs say no play for 3 weeks. Just depending. All right, so type 3, so grade 3 sprains of ligaments. So grade 3 is, if we didn't know this already, but a grade 3 sprain is a rupture, complete tear of the ligaments. You're going to have a good amount of edema. You're going to have a good amount of ecchymosis, limited painful range of motion, and then you're going to have this a positive deformity, and it's called a piano key sign. So it's called a piano key. I don't know if you could think about it, but if there was like a piano key, right, and you go to push that piano key down, it'll go down, but then it just goes right back up. Don't you just love my arrows? My arrows are like the worst thing in the world. I don't even know if you can tell what I'm showing you right here. So maybe, I wonder if we could, let's just search something real quick. Where's YouTube at? Let's see, piano key. Deformity. Ooh, I bet you this is good. Maybe we'll see. I'm gonna have to save this one for later, just real quick. Can't even hear nothing. Let's see how it looks. Is it gonna be a video? Not a good video. Okay. Oh, maybe is that just positive or? All right. Anyways, I think you get the idea. So a grade 3, so like a piano key sign. So if somebody has a grade 3, so here's 1, 2, 3, right? So you can see the clavicle is way up. You press it down, it goes down, but when you let go, it goes right back up like a piano key. All right. I feel like I just spent too much time to explain that. Sorry. But there we go. And then types 4 through 6 are really uncommon. You can see here type 6. So type 6 is where the clavicle presents inferiorly, and that's because of muscle guarding, right? So your pec major goes into muscle spasm and then pulls it inferiorly. AC joint sprain, so treatment, so type 1 through type 2, so rest, ice compression, elevation. NSAIDs, right? So NSAIDs, everybody knows NSAIDs, but they don't know what they are. So NSAIDs stands for non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs, and that's like ibuprofen. Okay. We'll do some rehab, work on some strengthening, and then return to play. So you can return to play when you have full range of motion and full strength. So type 3, we were talking about conservative versus aggressive treatment. So type 3, you're going to be in a sling for 2 to 4 weeks, or you could have surgery, right? So return to play anywhere between 3 to 10 weeks. Again, we want to avoid surgery. Type 4 through type 6, you don't have any options really. You're having surgery and you're going to be immobilized for 6 weeks. The only time I've ever even heard of that happening is in baseball. The outfielder was running to catch a ball and he ran like directly into the wall, and yep, type 6. All right, so glenohumeral joint sprains we're not going to talk about too much. So grade 1, so it's at the shoulder, right? The glenohumeral joint. So type 1 would be tender to palpation, limited. So we know ROM stands for range of motion. AROM is active range of motion, so they do it. There also could be passive range of motion. So passive, we do the range of motion. Okay. Grade 2, there'd be some laxity, some edema, some ecchymosis. Grade 3, there'd be severe laxity. Some might confuse that with being dislocated or felt like it dislocated. Decreased strength and range of motion. Treatments would be that typical rest, ice compression, elevation, the non-steroidal anti-inflammatory drug, sling, and then you just have to work your way back gradually. Now let's talk about tendinopathy. So tendinopathy is like the catch-all term for strains, tendinitis, and impingement, right? Just any type of pathology. Why do I keep on this color? I really need to get off this color. Okay. So tendinopathy, right? So we're talking about of the shoulder. So shoulder strains, tendinitis. So a strain is more acute, right? Oh my goodness. So a strain is more acute, where this is tendinitis is chronic. So supraspinatus, right? Super common. Rotator cuff muscle that's injured, right? The function of your rotator cuff is abduction, or of your supraspinatus is abduction. So the MOI for supraspinatus tendinopathy is overuse. So you overuse your shoulder, you get inflammation. Muscular imbalance is huge too, and scapular dysfunction. So muscular imbalance, I wonder. So basically, a lot of people, like if you were to look at yourself in a mirror right now, you're probably hunched over. So their chest is super tight, and their back is really, really weak, right? So the muscular imbalance, so chest tight, back weak. I want to try to start something. Everybody talks about skipping leg day at the gym. Like everybody skips back day. And actually that's changing, right? So I admit that's changing. More people are working on their back, right? So like rows and that sort of thing. It's super important to have that muscle balance. And then scapular dysfunction. So if your scapula moves shoulder. If your scapula doesn't move right, your shoulder is not going to move right. If your shoulder doesn't move right, you're not going to have good mechanics, and then you're going to have problems with your shoulder, right? It's that easy. So signs and symptoms. So signs and symptoms for, and I'm going to bring this down a little bit here. So signs and symptoms for this could be achy or sharp pain, decreased pain. When you got decreased pain when you start activity, tender tube palpation on the anterior lateral aspect. And this is for supraspinatus, right, of the head of the humerus. The special test for this is the empty can. Let me see if we could do this. Empty can special test is how you test for the supraspinatus. Let's see. And again, if we're
in this video, we will demonstrate the empty can test, also known as joke test for subacromial pain syndrome. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to PhysioTutors. In the 1970s and 80s, Neer coined the term subacromial impingement syndrome. According to his theory, impingement occurs on...
So subacromial, so the acromioclavicular joint, right? So subacromial is just inferior to that. Let's just get to the test here.
Are elevated to 90 degrees in the scapular plane.
So the scapular plane it's not out in front of you, it's not out to your side, but
the arms are then fully internally rotated so that the thumbs point towards the floor.
Empty can.
The patient
right?
is then instructed to resist downward pressure applied by the examiner.
Got it. And if they have pain with that, then it's possible that they have something wrong with their supraspinatus. So that's the empty can test. We'll have special test day. I don't know. Being distant learning really messes our skills up, but that's all right. Treatment modalities, rehab, and mechanics. Basically just fix everything that we outlined here, right? That looks terrible. You want to fix this, right? By rehab and mechanics. Shoulder impingement, so MOI, overuse, this is basically the same stuff, right? Structures, what I want you to know is that structures that can be involved, supraspinatus, biceps tendon, or the bursa sac, okay? And again, this is what we want to treat, which is all these problems. It's a better arrow. Now, dislocations, subluxations, and separations. All right, so let's talk about glenohumeral joint dislocations. Most commonly, it's going to dislocate anteriorly. And then, so reduction is reduce it, right? So again, we go back to it. If somebody dislocates their shoulder, don't just go grab it and try to put it back into place, right? If somebody dislocates their shoulder and they go to the hospital, what's the first thing that they do? Might give them pain medication. They don't put it right back into place. They take an X-ray to make sure it's dislocated. They don't want to just in case it was fractured. Okay, once you dislocate your glenohumeral joint, you're 80% likely to redislocate it. Pretty high, right? And then there's all kinds of complications, right? And it turns into a chronic issue. So MOI, definitely FOOSH. Signs and symptoms, deformity for sure. Limited range of motion. Apprehension test. So it's pretty straightforward. What is this? Let's see here. How to reduce. You see this? Senso more. I don't know. It's kind of weird. But essentially, it's sensory and motor loss, right? How would we test that? How would we know? Dermatomes and myotomes. Okay, so basically, you bring them into abduction, external rotation, and then it just slips back into place. Now this person has medication on board, so his muscles are a lot more relaxed, he's more relaxed. If you try to do this in the field, right, they're not going to be as relaxed, obviously, okay? But they've just had some medication, so they're nice and relaxed. So now it slips back into place. Okay, got that. Glenohumeral joint dislocation. So, treatment post reduction. So you want to immobilize for 3 to 6 weeks. So in a sling. You like these pictures I got you guys? Like these old school pictures of relocating stuff. Hi Jojo. And then here. I'm gonna just move this over here. So you want to immobilize, and then we're going to start with rehab. Okay, so starting of that rehab, you want to start with isometric exercises. So an isometric contraction is a contraction with no movement. And then you have, and we'll talk about rehab. He's okay.
I like Dada.
I got Enzo in here with me right now for a minute. So can you say hi?
Hi.
So you have, for the rehab, different types of muscle contraction, and we'll get to this, but the isometric muscle contraction is the first one that you're probably going to start with, which is where the muscles contract, but there's no movement. And then concentric is where the muscle shortens when it contracts, and then eccentric is where the muscle gets longer. Just as a side note real quick, so there's something called rhabdomyolysis. Rhabdomyolysis, I think that's how you spell it. But it's essentially where your kidneys become overloaded with the breakdown of muscle protein, and you could die from rhabdomyolysis. Just an extra credit. So if you do, it's been said if you do like a total body,
I want to sit on your lap.
if you do a total body eccentric workout, you could have rhabdomyolysis, right? Because eccentric is like the hardest on your muscles. It breaks down most of the muscle tissue, and that's why it's good. It's like doing negatives, right? I don't know if you've ever heard of that. But anyways, a little bit of side information. I'm not going to necessarily test you on that, even though it could be extra credit. And then we're going to talk about subluxations. So I know you've heard of somebody saying that you sublux your shoulder, or somebody sublux their shoulder. And that's like a dislocation. So comes out and pops back in. So it's either full or partial. It's either partial dislocation or full with a spontaneous relocation.
Dada,
Yes.
could I please even color on this?
Maybe when I'm done.
Okay.
So subluxation is where it comes out, but it's either full or partial, but it goes back on its own into place. All right. Shoulder impingement, we already talked about that. This is the last one we're going to do today. All right. Hooray, hooray. So there's 3 different complications of dislocations and subluxations. Enzo's got the hiccups if you could hear that. So you have a Bankart lesion, which is the ligament and or labrum tears off the glenoid. Okay, so here's the glenoid. Okay, and either this a ligament on there tears off, or the labrum itself. Sorry, that's not the glenoid. The glenoid is the bone. Okay, this white part is the labrum. So I need to make a note. Labrum and contractions. Something you guys need to watch. Okay, so that's Bankart lesion is when there's a dislocation or subluxation, there's a tear of the ligament and or the labrum, tears off the glenoid, which in glenohumeral joint, that's the socket. Then you have Hill-Sachs lesion, where during reduction a bone chips off the head of the humerus. Or you could have a SLAP lesion. SLAP stands for superior labrum anterior to posterior. And so essentially, and you can see it right there, the labrum tears off the glenoid, right, on the superior aspect, okay? I hope you guys maybe watch this over a couple times or in and out. I miss you guys a lot. And yeah, I hope this goes well for you guys. Can you say goodbye, JoJo?
Bye.
Say see ya.
See ya.